Hello and welcome. Today we're going to walk through an evidence-based guideline that addresses a very common clinical challenge. When should we refer a cardiac patient for specialized anesthesia care during non-cardiac surgery? Our purpose here is to create clarity with a standardized framework that prioritizes patient safety above all else.
So here's how we'll break this down. We'll start by establishing the clinical stakes, looking at the actual perioperative risk involved. Then we'll introduce the three-tiered referral system itself and get into the specifics for both mandatory Grade A referrals and recommended Grade B consultations. We'll also dedicate some time to the nuances of arrhythmias and cardiac devices before we finish up with the practical steps for implementing this guideline at your own institution.
All right, let's begin by establishing why this matters so much. The perioperative cardiac risk in these patients is significant, and the potential for very serious adverse outcomes is precisely why we need a structured, evidence-based approach.
When you look at the numbers, the risk in certain populations is truly staggering. The overall rate of major adverse cardiac events, or MACE, is somewhere between 3 and 9%. But that doesn't paint the full picture. For very high-risk groups, we're talking patients with severe pulmonary hypertension or Eisenmenger syndrome, mortality during an emergency surgery can be as high as 50%. That statistic alone really underscores why a specialized care pathway isn't just beneficial, it is absolutely critical.
So, to get a handle on this risk, we've put together a standardized framework. The idea behind this referral grading system is to give you clear, actionable guidance. It's really designed to help resolve those clinical disagreements that we've all encountered about what level of anesthesia expertise is truly necessary for a given case.
The system itself is pretty straightforward. It's broken down into 3 tiers. Grade A is a mandatory full transfer of anesthetic care to the cardiac anesthesia service. Grade B is where we recommend a formal consultation for risk stratification and management planning, which might well include co-management. And finally, Grade C, which allows for an optional consultation, really depending on your local resources and specific case complexities.
All right, let's get into the specifics of a Grade A referral. I want you to think of these as the absolute, non-negotiable conditions. These are the situations where the evidence clearly shows the risk is just too high for anyone other than a cardiac anesthesiologist working in a cardiac-capable operating room. For patients with WHO Group 1 pulmonary arterial hypertension and Group 4 CTEPH, the single most important thing to remember is this: the referral has nothing to do with the procedure. It is completely procedure independent. These patients are so exquisitely sensitive to hemodynamic shifts that even a minor case under sedation demands a mandatory transfer of care. The risk is inherent to the patient's pathophysiology, not the surgery itself.
And look, this isn't just our recommendation. The consensus here is crystal clear. The 2023 American Heart Association's scientific statement backs this up completely, really emphasizing the extreme caution needed for any anesthetic intervention in any patient with severe PAA.
Another absolute indication for a Grade A transfer is severe left ventricular systolic dysfunction. We're defining that as a left ventricular ejection fraction, an LVEF, of less than 30%, specifically when that patient is heading for intermediate to high-risk surgery. The risk of an acute perioperative heart failure exacerbation in this group is just substantial.
The same logic applies to critical structural heart disease. This absolutely requires a Grade A referral. This includes symptomatic severe aortic stenosis, which carries a relative risk of 2.3 for adverse outcomes because of its fixed cardiac output. It also includes hypertrophic obstructive cardiomyopathy, or HOCM, with a significant outflow tract gradient, which we define as greater than 30 millimeters of mercury. In these patients, anesthetic-induced changes in preload and afterload can be, quite frankly, catastrophic.
And finally, when we look at the adult congenital heart disease population, there are 2 conditions that really stand at the apex of risk. These are non-negotiable Grade A referrals. We're talking about any patient with single ventricle physiology, and that includes all stages of palliation like the Fontan circulation, and any patient with Eisenmenger syndrome.
Okay, that covers the mandatory transfers. Let's move on to Grade B conditions. This category is for patients with significant cardiac disease where, while a full transfer isn't always mandated, a formal consultation is strongly recommended to optimize their care. One of the most critical factors we have to consider is timing, especially after an acute coronary event. Urgent surgery within 60 days of a myocardial infarction, an MI, that's a Grade A referral. The myocardium is just too unstable. But after that initial high-risk period, from 60 to 180 days post-MI, the risk profile changes, and the guideline shifts to a Grade B consultation. This allows for a collaborative discussion about the optimal timing and management strategy. The same basic logic applies to recent coronary stenting, where we're balancing surgical need against the risk of stent thrombosis.
Grade B also applies to a whole range of conditions that we'd classify as severe but stable. This includes asymptomatic severe aortic stenosis, moderate pulmonary hypertension from groups 2, 3, or 5, and an LVEF between 30 and 40% in patients scheduled for higher-risk surgery. In these scenarios, getting that expert consultation is really the key to developing a tailored anesthetic plan that's going to prevent decompensation.
All right, let's shift gears a bit and talk about electrophysiology. Cardiac arrhythmias and the various implantable devices out there present their own unique set of perioperative challenges, and the guideline addresses these very specifically.
And this is where the guideline makes a really critical distinction, and it's all based on the immediacy of the risk. A Grade A transfer is mandatory for high-degree AV blocks, like an unpaced complete heart block or a Mobitz type 2, where there's an imminent danger of progression to asystole. In contrast, inherited channelopathies like long QT or Brugada syndrome are Grade B. They absolutely require expert consultation to mitigate arrhythmia risk, but not necessarily an automatic transfer of care.
So this table gives you a quick summary for managing key cardiac devices, but if there's one thing to take away here, it's about LVADs. Patients with a left ventricular assist device, an LVAD, almost universally require a Grade A transfer. Their unique, non-pulse-style physiology and absolute dependence on the device demand it. For patients with ICDs or those who are pacemaker-dependent, a Grade B consultation is recommended to create a solid plan for managing electromagnetic interference, which often involves reprogramming the device and ensuring appropriate backup is in place.
When it comes to atrial fibrillation, it's the acuity of the situation that really drives the referral grade. Uncontrolled AF with a rapid ventricular response is an active cardiac condition. It necessitates a Grade A referral for stabilization. Now, for patients with chronic but poorly controlled AF, especially if there's underlying structural heart disease, a Grade B consultation is the appropriate path for preoperative optimization.
So, now that we've walked through the clinical criteria, let's talk about the practical side of things, implementation. Because, let's be honest, a guideline is only as effective as the institutional structure that supports it.
For this to be successful, it really hinges on a few key components. This means having clear, written referral pathways. It means leveraging your preoperative optimization clinics. And critically, it means having a formal process for conflict resolution when disagreements arise. Beyond that, continuous improvement requires tracking key quality metrics and holding regular multidisciplinary case reviews to learn from the complex cases we all encounter.
Now, one of the most important quality metrics you're going to want to track is something called MINS, or myocardial injury after non-cardiac surgery. This is defined as a prognostically significant injury due to ischemia, and it's detected by a rise in post-operative troponins. Ultimately, a primary goal of this entire guideline is to systematically reduce the incidence of MINS in your patient population.
So let's pull all of this together. The ultimate goal here isn't just a checklist, it's to create a systematic, evidence-based framework. This is about balancing patient safety with the rational use of our specialized resources. Success really requires integrating patient-specific factors, the inherent risk of the surgery, and the unique capabilities of your own institution.
So I'll leave you with a question to take back to your own practice. Does your institution have a clear, evidence-based, and, most importantly, consistently applied pathway for managing these high-risk cardiac patients? The answer to that question is fundamental to perioperative safety. Thank you.